focal, so it is a lens that has two foci, or a glasses that has two foci. So why do we need to wear a bifocal lens, or why do a patient can wear a bifocal lens? We all know, as we mentioned yesterday, about presbyopia. So presbyopia meaning that it is recession of the near point. So the patient is no longer able to see the near targets clearly. And this will mandate that the patient should wear a glasses for near vision. Sometimes the patient got annoyed that he has two glasses, so he may wear a glasses for far vision and another one for near vision, and hence the importance, or the benefit of bifocal lens, that in such condition we can combine both glasses in single glasses. So we can combine a far segment to look for the distant targets, and we can combine another near segment to look for the near targets in just one glasses. So the patient doesn't need to have to take off the glasses and wear another one while they are looking from the near to the far, so they can see both of them in the same time. There are different types of lens that incorporate both near and distant correction. So we have the bifocal. So in the bifocal lenses, they have two segments, one for near and the other for far. And we have the trifocal. So the trifocal, by as it's evident from its name, you will be able to see the near and the far, and there is a third segment, and this will be for the intermediate distance. The varifocal, or the progressive power, this lens can also see for the near and far and the intermediate distance, with gradual transition in between these lenses. Most of our talk will be about the bifocal lenses, so let's start. So as we said, the bifocal lenses are a single pair of spectacles that combines both near and far segments. So the upper one usually will be for far, and when the patient looks down as he is converging and looking to a near target like reading a book, then he will look through the near segment. So this single glass will combine both near and far vision. So why does a patient need to wear bifocal lens? As we said, the first indication, or the most common indication by far, will be presbyopia. So the patient needs to wear these lenses in order to overcome the recession of the near point that occurs after the age of 40, and so that they don't need to wear double glasses, just one single glass for near and far. The other indication is aphakia. So aphakia in the aphakic patients, they are devoid of lens, so they don't have a lens, and since then they don't have accommodation. So by not having accommodation, these patients will have a problem with near vision as well as the far vision. So they will need glasses that will correct the error of refraction for far, but they will need extra add lens for near vision to compensate for lack of accommodation. There is a specific type of accommodative convergent squint that is called the non-refractive accommodative convergent squint. In such a condition, the patient will have no problem with far. So when they are looking to a distant target, the eyes are well aligned, as you can see here. But the problem emerge when these patients look at near. So as you can see here, when the patient is looking for a near target, there is inward deviation of the eye. And this occurs because of what is called abnormal high accommodation convergence to accommodation ratio. In such condition, the patient will have high convergence in relation to accommodation. That's what make the patient show a convergent squint on looking in the near target. So since the patient is normal for far, we need a correction for only for the near, and this is what comes the rule of the bifocal segment. So the bifocal segment will just will be a plus add for the in front of the patient's eye while he is looking for a near target. So this patient doesn't need to accommodate. That's what will make the patient doesn't need to converge. So this will eliminate the convergent squint by elimination of accommodation via the bifocal lenses. Also, it can be used for neurological disorders that affect accommodation. For example, if there is a stroke affecting the midbrain, for example, and the patient cannot accommodate, then this plus lenses will be of great value. The main four types of the bifocal lenses will be the split bifocal, which is the early generation of bifocal made by Franklin, the cemented bifocal, the fused bifocal, and finally the most recent innovation or the most recent generation for the bifocal lenses will be the solid bifocals. So let's first start with the split bifocal or Franklin bifocal. They are named after Benjamin Franklin, who has invented these bifocals more than 200 years ago. So before the Benjamin Franklin thought of making up these lenses, because he was like any other old guy, he is presbyopic, and he needs two glasses for far and near. So he thought, why don't I combine them in one glasses? So here we made it. He make a single glass that has upper far segment and the lower near segment. So he combined both of them in single glass. Just but in the early frames or in the early generations, there were even no frame for the lens. So it was even joined by just a wire. So a wire was combining the near and the far segment, so that the upper segment will be for far and the near segment will be at the bottom of the frame. So this was the earliest attempt of making a bifocal lens. So the two segments will be combined with the single glass, and there will be a horizontal line separating both of them. So what are the advantages and disadvantages of this innovation? First of all, it has a large field of view, since the lower segment has almost half of the field, or half of the glasses are made up of the near segment. So the near segment has a very large field of view. The optical center of the both distant and the near portion are at the dividing line, so it will eliminate a phenomenon that's called prismatic jump. Prismatic jump is a phenomenon occurs due to bifocal lens. While the patient is looking downward, he finds out that the object is jumping upward, and this has an explanation that we will mention at the end of this lecture. But just to say now that the Benjamin split bifocals can eliminate this prismatic jump because it has the optical center of the near segment and the far segment are near to the midline or near to the split line, and this is the condition which will eliminate the prismatic jump. Also, it has a less chromatic aberrations. So chromatic aberrations arise if we use a lens of different materials. So if we combine different materials of different refractive indices into single glasses, then this will result in chromatic aberration. And this is not the condition here. So does it mean that it doesn't has any disadvantages? The answer is no, because this is like an early generation and it is no longer used because it has a lot of disadvantages. The earliest generation was combined by eye wire, and they can be easily separated from each other. This is not the condition nowadays, but there are other disadvantages that will downgrade this split bifocals. The dividing line between the upper and lower segment will cause annoying reflections that will annoy the patient, and even the dust will accumulate in this dividing line. And the cosmesis is also a concern, because as we increase the add power in the near segment, the glasses looks cosmetically unacceptable and unappealing, so the patient may complain of this as well. Also, if the patient has a cylindrical power, then it will be difficult to combine this cylindrical error into the glasses. So this was the earliest generation, as I told you. And then we moved, or we shifted to another era of bifocals that is called cemented bifocals. Cemented bifocals meaning that we need to construct a near segment that is placed over the far segment. So it is not by splitting the upper and lower, but it is a far segment with a near segment that is adherent to it. So a near segment is constructed by attaching a supplementary wafer lens to the surface of the distant lens by which, and they are both of the same refractive index. This is very important. And in order to make both of them adherent to each other, we use an adhesive material that is called Canada balsam. So Canada balsam are used as an adhesive material for cemented bifocals. All the blue things, or that is in bold and underlined, are areas of MCQ questions in the exam. So you need to pay a great attention to them. So again, what are the cemented bifocals? The cemented bifocals are a constructed lens. These constructed lenses are formed by a near segment that is called a supplementary wafer lens that is attached to the surface of the distant lens, and both of them will be of the same refractive index, and they will be attached to each other using an adhesive material that is called the Canada balsam. So here we can see that this is a distant lens that can make the focus over the F or over the retina, and now we need to put a supplementary wafer lens. This is the near lens. That's, as you can see, it is in the meniscus form, so it has the front surface of +5 and the back surface of -2. So there will be the net result will be +3. So just by putting it on the anterior surface of the distant lens, then adhere and attach it using the Canada balsam. So then we will have the cemented bifocal. So you like construct a building, you can notice that it is called cemented, coming from the cement. So cement is used as a material that will used in construction of buildings and making the brick walls or the bricks adherent to each other. So it will be the same idea. Also, please notice that the attached segment here is of the same refracting index, so that these patients will not complain from chromatic aberrations. There are a modern form of the cemented bifocals, which is the Fresnel lens. The Fresnel lens can be stuck in place with water or alcohol, and it can be used sometimes as a temporary bifocal, but it is cosmetically unappealing and expensive, and optically poor for permanent use. So they are not used for permanent use, but they can be used for temporary bifocal lens. And what is asked in the MCQ, that what are the materials that makes it adherent to its to the lens, will be the water, or what makes it sticks in its place is water or alcohol. So let's again come to the advantages and disadvantages. What are the advantages of the cemented lenses? They are cosmetically more acceptable. than the split bifocal, of course, and they have less optical aberrations because they are made, the near and far segments are made of the material of same refractive index, and they can be made of any power range and positioned anywhere. Since they are, it is just a wafer lens that is constructed or become adherent to the surface of the lens. We can put it anywhere and we can construct it with any power size. And even they have a specific importance in patients who have low vision. So if the patient has very poor visual acuity, they can be made to stick over the surface of the lens with high plus power in order to increase the magnification. And this will be mentioned in the next topic, which will be the low vision aid. So in case of low vision, if the patient has special needs, we can use this cemented bifocal as a high plus aid over the distant glasses in order to increase magnification of the near, increase magnification for better appreciation of the near tasks. The disadvantages of the cemented bifocals, that again we have a dividing line, and this dividing line tends to collect dirt and dust, and it can be affected by changes in temperature, as the Canada balsam can be crystallized or discolorized or discolored. So this should be one of the drawbacks of this type of bifocals, that the Canada balsam or the adhering material will undergo degradation and the changes in relation to the environmental factors. So this also is asked in the MCQ. And also the wafer has a tendency to fall off. So this lens, which is supplemented over the main lens, can also fall off if the Canada balsam show degradation. The third type, or the next generation, will be the fused bifocal. So fused bifocal meaning that we will combine two lenses of different refractive index. So by putting a small part of lens of high refractive index glass at the lower part of the lens, then we can increase the power of this lower part in order to allow for near vision. So this is the fused bifocal. We can construct it by just making, this is the distant lens, and by making a concavity at the lower part of the distant lens and placing a material of high refractive index, then we will be able to have a high power lower part of the lens, which will be sufficient for near vision. So as you can see here, it was manufactured by making a groove or a curve at the back, in the front surface of the major lens, like here. Then we supply the material of higher refractive index to be placed in this groove, and then finishing the bifocal will be both of them will be fused together, so that this lower part will be able to see the near vision and the upper part will be for the far vision. So basically the fused bifocal are combining two materials of two refractive index. The most material used here will be the crown glass, which has a refractive index of 1.5, as we all know. So this will be for the distant vision, and while the near segment or the near part will be made of the flint glass. Or the flint glass, as we all know, it is a compressed glass that has a refractive index of 1.8. So the flint glass in the near segment will be able to have a better refraction or more refraction, and increasing the plus power, so it will be suitable for near vision. This can the fused glasses can take many forms, so they can combine. They can be show what's called the D-top or the flat top. So in the flat top, the upper segment or the upper part of the of the near segment will be invisible because it will be made of the crown glass, the same like the main lens, which will be made also of the crown glass. And then suddenly it will show the flint glass, which will be the near segment. So it like there will be an invisible part which is made of the crown glass as the main lens, and while the flat top and or the splitting part, it will be responsible for the flint glass. So this all will be made of the flint glass. This is called the flat top. There is another type which is segmental. So in the segmental, there will be having a crown glass above and the crown glass below and the flint glass in between. So let's come to the advantages and disadvantages. What will be the advantages? Here we don't have any dividing line. So there will be no line that will connect that will collect dirt or dust because it is fused. It is not split and it is not cemented, and so there will be no dividing line in between the distant and the near target and the near segments. They are will be both fused together, so the interior surface, as you can see here, it is a smooth, it is nice and smooth. There will be no any dividing lines. Also, since we don't have a cemented segment, so that segment will not fall out or become discolored or it will be torn, and it is relatively lighter than the cemented and the split bifocals. But does this mean that it has no disadvantages? So can you tell me from your understanding what will be the expected disadvantage of this bifocal? Since I told you that it is made of materials of two different refractive indices. Exactly, Dr. Hassan. Exactly. So it will be the patient will suffer from chromatic aberrations. So the flint segment will produce high chromatic dispersion and the high chromatic aberrations. So the patient, it is not unusual that the patient will experience to see some color fringes and some halos of different colors. It is will be due to chromatic dispersion and the chromatic aberrations. So a specific type of the fused bifocal will be, as we mentioned, will be the flat-topped bifocal or the D-shaped bifocal that has a near button. This near button has the upper half of this near button made of the crown glass, so it will be of the same refractive index like the main lens, and the lower part of this near segment will be made of the flint glass, which has a higher index, and the separation between both of them will be this line. So this flat top is not the separation between the near segment and the far segment, but it will be the separation between the flint glass and the crown glass of the same near segment. So the upper part of this button will be invisible as it is made of the material of the same refractive index as the distant glasses. Only the boundary between the flint and the crown glass will be visible here. This is the flat or the D-topped or the D-shaped or the flat top. Here is the distant lens and here is the near lens. As you can see here, it's like letter D or it has a flat top. So what are the advantages and disadvantages? It is cosmetically more appealing, so it is not unsightly, and it shows less optical aberrations. So by making the near segment made of two materials, the upper part of it will be made of the same refractive index like the distant glasses, will decrease the incidence of optical aberrations and the chromatic aberrations. So it will be like a modification of the normal fused bifocal lenses. Also, it will show less prismatic jump and image jump and prismatic effect, as we will see later on at the end of lecture, and it will be lighter in weight. But the disadvantage is that it is you can say it is invisible, but if you have a clear inspection over it, you will be able to see it. And by making this the change, or by making these changes in the near segment, making the upper part made of the crown glass, we now reducing the reading area. So the reading area, or the visual field for reading, is somewhat reduced. And the dividing line can cause some certain problems between that of the crown glass and the flint glass. This can be causing some problematic issues like climbing the stairs. So it can intervene in the field of view, making the patient stumble over the stairs. Another type of the bifocal lens, it is called the solid bifocal. In the solid bifocal, they are made of the single material. So remember S for S, solid for single. So unlike other types of the bifocal lenses, they are made of the single material. So if it is made from single material, how can we compensate for the reading aid? This can be done simply by changing the curvature. So by increasing or the alteration of the curvature of the lower part of this bifocal, we can increase the power of the lower part to accommodate for the reading aid. So it's one of the most common used bifocal lens used nowadays, and the reading part can be, as I told you, by changing the curvature of its surface. So if we need to add cylindrical lens, so if the patient has a cylindrical power as well, how can we add it? So the cylindrical power is added into the posterior surface of this lens, while this is the near segment. As we can see, it is changing the curvature of the lower part, will make the lower part of this lens suitable for near vision. But if the patient needs a cylindrical power, then it will be grounded on the posterior surface of the lens. So what will be the advantages? As I told you, it is a single material, so it will be the single refractive index, so there will be no chromatic aberrations. And there will be absent contact surface between the two portions, so there will be no split line between both of materials, or both the upper and lower part. There will be wide field, and it will be a thin lens. So it has a very good advantage, or very considerable advantages. So it is one of the most used, as it's mostly avoided all the disadvantages that occurs in the earlier generations. So it avoided the chromatic aberrations that occur in the cemented bifocal and in the fused bifocal. Sorry, in the fused bifocal, it avoided the collection of dirt and dust that occur in the split bifocal and in the cemented bifocal. It avoided the problem of narrow field that occur in the flat top D-shaped bifocal, and it is a thin lens, so it is not like the cemented bifocal, which is thick and heavy. A specific type of the single or the solid bifocal, it is called the curved top bifocal lens, or Altix. What are the characters of the Altix or the curved top? It is a one-piece bifocal made of the ophthalmic crown glass. So as we mentioned, it is made of the single material. By just changing the curvature, it will be able to see or we will be able to incorporate reading as well. But here the reading segment, or the changing in the curvature, is on the back surface of the lens. So changing the back surface of the lens curvature will account for reading segment, as you can see here. This is the Altix. This is the Altix. As you can see, by increasing the curvature of the back surface of the lens, as you can see here, this lens is now able to see the near vision. So what are the advantages? Again, since it is made of a single material of crown glass, it will show less chromatic aberrations, and it will show larger field of view for reading option as well. But the disadvantages of this lens particularly that it can produce more prismatic jump and prismatic effect. The final part, or the last part, the last type of the bifocals, it's called the executive or the full field bifocal. And as it is evident from its name, one of the major advantages of this bifocal, it will be that it will increase the field of view. So the near segment here cover almost half of the lens. So this type of lenses will be of particular importance in patients who have more demanding near tasks. So they tend to use it for most of the time, or their visual tasks are more toward the near side. That's why we need to give them glasses that will have a large field of view, so that the lower segment here will cover the entire lower field. So you may wonder, okay, but this is looks like the split bifocal, as we have near segment to cover the entire half of the lens. This is can be true, or can be somewhat true, but here the optical center of the reading portion is on the dividing line, so that here there will be no prismatic jump. So we say that the prismatic jump occurs if the optical center of the both distant lens and the near lens are away from each other. But as long as they are close to each other, and if they are present at the dividing line, there will be no prismatic jump. So the patient looks, while the patient is looking for the distant, or the patient looks at the near, he looks at this center or at the dividing line, so there will be no prismatic jump. Advantages: the most important advantage is that it has a very large field of view, and it has less chromatic aberrations because both segments are made of the same material, and it will show no or minimal prismatic jump. But the disadvantage is that it is heavy and it is ugly, as we said in case of the split bifocal. And there will be a dividing line, so dust and dirt will tend to accumulate in the dividing line, and the edge of the segment can chips easily. So you can see that it is like the same like the earlier generations of split bifocals by Benjamin Franklin. It is just with a slight improvement. So these are the different types of bifocal lenses. So here to summarize, this is the flat top, or the D-shaped flat top bifocal. This is the shape of the executive. As you can see, it is ugly because you can see that the half of the lens is for far and half of the lens is for near. So increasing the near segment doesn't come without a price. It comes on the expense of the cosmetic appealing of this lens. The rounded bifocal, or the Altex, which will be the one single type of the or one type of the solid bifocals. After knowing what are the different types of the bifocal lens, let's know what are the distant and the near visual points. We have two important points, which are the center, or the optical center of the distant lens, and the optical center of the near lens. So the optical center of the distant lens, it is called the distant visual point. And the optical center of the near lens, it's called the near visual point. So in which these are positions on the lens at which the visual axis will be directed while the spectacle in use. In order to have decrease the prismatic jump and decrease the drawbacks from the bifocal, the near visual point should be 2 millimeter nasal and 8 millimeter below the distant visual point. As you can see here, as we all know, while we are reading, the eyes tend to look downward as we look to the book or read, and the eyes converge. So we need that the near visual point to be on the nasal side, so it will be inward, and to be slightly downward. So it will be nasal to the distal visual point and below the distant visual point. So why do we need to wear a bifocal lens? Prescribe bifocal lens for a patient. The first indication, which is the most common indication, as we mentioned, will be the presbyopia. So the lower segment will be used for the near, and the upper segment will be used for the far. So by combining both lenses in one lens, we will enable the presbyopic patient who has a problem with his near vision to see clearly for both far and near in just single glasses. Also, aphakia, as we mentioned, these persons will have lost their accommodation, so we need to compensate for both distant and reading. Myopia with weak accommodation. So if a patient has myopia, they usually will have a weak accommodation. And this is because their eyes are powerful, their eyes are strong, and they don't have any problem to see the near target. So they don't tend to use their accommodation to look at a near target. So what happens if we fully corrected these patients with myopia? If the patient with myopia has full correction for far, they will be able to see the distant targets clearly. But the problem, if he looks at a near target through this full correction, because if these patients will have a weak accommodation. So if we do a full correction, so we give the patient the full minus power of their lenses, and they look for far, they will be having no problem. But if they are looking at near, they tend to have a strain, eye strain, and the headache because they have weak accommodation. So this weak accommodation is not able to overcome this strong full correction. So what can we do? We can give them bifocals. This bifocals, in the upper part of the bifocal for distance, we have the full correction, but in the lower part, we will have under correction. So the under correction will allow the patient not to cause much strain over his accommodation. So his weak accommodation will be safe, and he will not be able, he is not forced to struggle to overcome the strong minus power of the lower segment. Hypermetropia with accommodative convergent squint, as I mentioned earlier, patients with hypermetropia sometimes can show abnormal relation between convergence and accommodation. So they exert a lot of convergence in relation to accommodation. That's why their treatment will be to resolve the accommodation, to prevent them from accommodating. So by making the patient has the distant correction in the far segment, but in the near segment or in the lower part, they will have like +2 or +3. So they will prevent this +2 or +3 will prevent them from accommodation. So it will prevent this. So the accommodation reflex will not be stimulated, so that the convergence will not be stimulated, so the patient will not experience any esotropia. Also, if the patient is under cycloplegic and need nerve work, so if you have, for example, patient who will be on cycloplegic eye drops for a longer time, like for example, patients with uveitis, and then these patients who should be a candidates for the bifocals. So they will be complaining from the near work due to relaxation of the ciliary muscle, so they will need to compensate for this weakness of accommodation or paralysis of accommodation by bifocal lenses. What are the contraindications for bifocal lenses? It can be very logic that patients who have more demanding visual tasks, it will be prohibited from wearing the bifocal lenses. For example, if the patient has a handicap, or the patient is handicapped and limping, so this patient will more likely to stumble as he wears the bifocal, because this patient doesn't have a steady gait. So these patients will not maintain the same visual axis all the time. So they will, the bifocal lenses will most likely cause them some problems. Also, vertigo patients will experience the same thing. They will not be, they will not having some steady gait, so they may fall off on the ground if they use the bifocal lenses. Some occupations like sailors and soldiers that tend to look at the different levels of environments. So when sailors look at the sea and look at the ship, soldiers look at the mountains and look at the hills, and the builders who tend to ascend up or descend down all the time. So the bifocal lens will be of problematic to their vision. Sportsmen needs wide field and they don't need to look for the near target. So sports doesn't require near tasks, so they will not be a good candidate for bifocal lens. If the patient has high astigmatism, this will lead to prismatic effect, which will interfere with the function of the bifocal lens. Also, high anisometropia will cause prismatic effect as well, so it will be problematic in these patients. Finally, let's discuss the disadvantages. All the lectures we have been mentioning something called the prismatic jump. So it's now time to know what is the prismatic jump. Also, there will be a prismatic effect that occurs specifically in myopes. So this should be considered while prescribing a low vision or prescribing a bifocal lens for myope. Decrease the visual field, and finally the oblique astigmatism. So let's start first by prismatic jump. What is the prismatic jump? The image jump is meaning that while the patient is looking, if the patient is looking to a target through the distant lens, and then suddenly he moved by his eyes downward, so he now is looking through the near target, he finds out that this target will jump up. So the eye will look down, the target will jump up. This is called the prismatic jump, and this occurs because of the prismatic effect of the lens, of the plus lens. So again, what happens in case of the prismatic jump? It will be the sudden upward displacement of the object while the eye moves from the distant to near. So if the eye is looking to a distant target, then suddenly looks down at the near target at this smiley face. So as the eye looks down, the smiley face jump up. Again, as the eye looking into the distant, there will be no problem. If the eye is starting to look through the near segment to a point of interest in the near area, this point of interest will jump up. This jump is totally dependent on the near edge, and the distant segment has no role on it. This is because of the prismatic effect of the near edge. So the prismatic jump can be avoided, or there are specific conditions in which if we use the optical center of this segment is at the top of this segment, there will be no prismatic jump. As we said, the more we approximate the near vision point and distant vision point to each other, the more we minimize the prismatic jump. And this prismatic jump occur more worse in the bifocal lenses which has a round top bifocal, because as we mentioned, the near visual point and the distant visual point will be far from each other. So it will be like this, and it is, if there is a round top, then this will be the optical center of the near point, and this will be the optical center of the distant visual point. But if we use a flat top, like a D-shaped flat top, we said that it has a less prismatic jump, because here will be the distant and here will be the near visual point. So they will be close to each other, so that it will minimize the prismatic jump. So how to minimize or how to prevent the prismatic jump? So the first thing is to make the near visual point and the distant visual point as near as possible, or even monocentric as in case of the executive bifocals. So we can make them on the dividing line. And also we can add a prism to compensate for the prismatic effect of the reading portion, meaning that the reading portion, while the patient is looking through the reading portion, the plus lens here act as a base down prism. So again, as the patient is looking through this target, so that the patient is looking from this segment, or this segment of the near part, so it is a base down prism. So how can we compensate for a base down prism? Just to simply add a base up prism. So by adding a base up prism in the near portion, we will now eliminate this prismatic jump. So here again, this is the base down prism of the effect of the plus add. So if the patient is looking to the distant target, there will be no problem. If they are looking down, then there will be a prismatic jump. The object will be jumping upward, because that the rays from the object will pass through this prism, and the rays will be deviated toward the base, so that the eyes and the object the object will deviate toward the apex of the prism, as we all know from the prisms lecture, so that there will be a prismatic jump. But what happens if we add a base up prism? It will neutralize the base down prism of the near add, so there will be no prismatic jump. For those who joined our course late, they may have some difficulties with that the understanding of some basic concepts like the prismatic effect. So I suggest that you start to study the optics. Okay, Dr. Hassan, you start to revise from the early lectures, because as I told in the first early lectures, that optics is built or based on each other. So every lecture is based on the previous lectures. So you have some fundamental knowledge by studying the geometric and the physical and geometric optics and the human optics. That's what will make you understand the concepts that we are discussing now. A second problem that comes with the bifocal lens is specific to myopes. And again, this occurs due to the prismatic effect. So as we know that the myopes can be considered as a apex to apex prism. So here is the minus lens. So the minus lens can be considered as an apex to apex prism. So the base is down. So if the base is down of the minus lens, and we already mentioned that the near add also has a base down prism, so we have now combining both base down prism of the near add and the base down prism of the myopic lens. So there will be a combined prismatic effect of base down of both lenses. So this is a significant problem in case of myopic glasses. But this problem is not present in hypermetropia, because as we know that the hypermetropia can be considered as a base to base prism. So the apex will be down, and if we combine a near glass or a near add that has a base down, so it will be base down in the near add and the apex down in the plus lens, so they will cancel each other. So the problem occurs in the myopia that have this effect, or this combined prismatic effect. It occurs more at the near visual point. So how to prevent? We can simply say that we can add a prism base up like here. So if we have combined prismatic effect, we can add a base up prism to neutralize this base down prism, or we can bring the near visual point to be close to the dividing line, as in case of the executive and the flat top and the curved top bifocal, or we can bring the optical center the distant optical center toward the near visual point in case of other types of bifocals. Other problems that can occur with the bifocals, as we said, they will decrease the visual field, which will be the minimal for the executive bifocals, but it is a general problem with all bifocals because we restrict the area for distant vision for the sake of the near vision. Also, oblique astigmatism is a significant problem because the patient is looking through the near segment of the visual axis is oblique to the optical axis. So while the patient is looking here to the near segment, the visual axis is oblique to the optical axis. So the optical axis will be here and the visual axis will be here. So there will be oblique to each other. So this can be overcome by the patient, or if the patient uses a toric lens, it can be easily overcome. There are other types of the multifocal of bifocal. So we said that we have the bifocal lens that combines both segments, one for near and the other for far. And the other type here will be called called the trifocal. So the trifocal lens are lenses that will combine three segments. One segment will be for near, and the other segments will be for far, and there will be a third segment, and this third segment now is for intermediate. So, for example, if let's say that a patient has very minimal accommodation, so this patient can see the distance, so they doesn't need accommodation. And when they are looking for a near target, they will look through the near segment, so they will doesn't have a problem. But what happens if they look for an intermediate distance? Like, for example, if they are looking for they are working on the computer, so they need some correction for the intermediate work because they have little or no accommodation, and hence the importance of the trifocal lens. So if the patient needs the intermediate distance a lot, then the trifocal lens will be of great value because it incorporates an intermediate segment that will allow this patient to see the at intermediate distance clearly. Also, if it's worth mentioning that these patients who are on trifocal lenses will not tolerate it if they are anisometropic. So if they have anisometropia, they will not tolerate the trifocal lens, or if they require some prisms for vision, they will not also tolerate the trifocal lenses. Finally, or the final part is the final type of bifocal lenses will be the progressive lenses. So what are the progressive lenses? These are lenses that gradually change between the near and far segments and can be used for all distance. So unlike the trifocal, they don't have a separate a clear separation between the near and far and the intermediate distance, but they are mingled together. So you can find that this is for distance, and there is a narrow corridor for the intermediate vision, and finally at the lower part will be the near vision. So what will be the difference between this is the simple bifocal showing the distance here and the near here, while the progressive bifocal showing the distance and the narrow corridor for intermediate then the near. So here is the anatomy of the progressive lens. This will be the distance. Then there will be a narrow corridor for intermediate that will connect the distant to the near segment. And on both sides of this corridor will be the blending region. So this blending region will also allow the patient to see for the intermediate to allow the patient to see for the intermediate distance. So let's see an example. As you can see here, this is the progressive lens. So you can see that the upper part here will be able to see the distant target. Then there will be a narrow corridor like here that will, so it should be here, allowing for the intermediate vision, and then there will be the area below, which will be for the near targets, and this is called the blending regions. So this is the end of the first part, which is bifocals. Did you understand it? Do you have any concerns or doubts regarding the bifocal lenses, or do you understand it well? Well, the blending region will be important for the construction of the lenses. So the blending is just to make the smooth transition between the intermediate and the smooth transition between the far and the near. So it will passing through the corridor of the intermediate, and this blending region would allow this smooth transition. And also it was I think that I read some time or once in a book that the peripheral corridor or the peripheral part, the blending region, is like opaque because it is the in these glasses the aberrations are much more in the periphery. So by making the periphery opaque, then this will block the aberrations and prevent any distortion of the vision that the patient may have from this type of glasses. Okay, just hold on for a second, please. Okay, so let's now discuss the topic of low vision aids. This is like a very, very easy topic. It's just general informations about what are the low vision aids that are used in conjunction with patients who complain from low vision. So starting with low vision, let's have some basic concept about what is low vision and how can we define it. Low vision can be defined in the term of a legal blindness. So legal blindness meaning that these are patients who have the best corrected visual acuity less than 360 for distance in the better eye. If the patient cannot achieve with the best corrected visual acuity more than 360, then this patient can be considered as a legally blind. Not only the visual acuity is of concern here, but also the visual field. So sometimes the patient can achieve 6/6 vision, but they have restriction of the visual field, so they cannot they see the world through the keyhole, or they have what's called the tubular vision. That's the famous example for this is patient with advanced glaucoma. So if the patient has a central field that has only the central field less than 20 degrees from fixation, then this patient is considered legally blind. So if the patient, this is like the normal person, but this patient can only see the scene. So all this is now blind. All this now is damaged. So the patient can see the periphery but only can see the center. So if the patient can see only the central 20-degree from fixation, then this patient is considered legally blind. The WHO has different definitions for low vision. So by the WHO, the patient who have low vision is a patient who has vision is less than or between 612 to light perception. This will be the patient who, according to the WHO, that will need visual rehabilitation, and or if the patient has a visual field less than 10 degrees from point of fixation. So in either condition of these, the patient will not be able to maintain his normal day-to-day tasks or maintain his good quality of life by having good vision, and this patient will need some aid to enable them to look to see clearly or to see normally or near normal, and this is here comes to the role of low vision aids. So what are the common reasons for low vision? This can be done or can be caused by corneal opacity and dystrophy, like corneal scars, like trachomatous corneal scars, for example, in the developing world, and dystrophy is more common in the developed world. Also can be due to scars in the macula, like senile macular degeneration, which is more common in the developed world. Can be due to optic atrophy and other causes. So for these patients who experience low vision, we prescribe them low vision aids in order to improve their quality of life by improving their visual functions. So the principle of low vision aids, they are all work by the same mechanism. We need to have a magnified view of the object. These persons or these people needs to see a magnified image for the object. By seeing a magnified image of the object, we can stimulate a larger number of photoreceptors, and now we will have a better view of the object. So what are the types of or categories of the low vision aids? We have two main categories. We have the optical and the non-optical. So what will be the difference? We will see. Here are the types of the optical visual aids. Optical visual aids are aids that are used in conjunction with the eye and are used to provide a magnified image for the target. This can be either a magnifying high plus glasses, so the patient will wear a high plus lens in order to obtain a magnified view of the target. So like this is a 5x glasses that, as you can see, it can enlarge the letters, so the patient will be able to see them more clearly. Or the use of magnifying lens. This magnifying lens also can be considered an optical visual aid, or prismatic lenses can be used as a low vision aid, telescopic lenses that can be incorporated into the glasses, and finally the contact lenses can also be used as a low vision aid. So let's start also. Let's also check the non-optical visual aids. So these are doesn't have any usually doesn't cause a magnification. So they can be either the pinhole spectacles like this, which act as a pinhole allowing only the central vision, or reading slit, which allow improve the reading for patients, illuminating devices, large printed box, talking box, and video magnifiers. So here, this is just a summary for the low vision aid lectures. So in this lecture, we will go through each one of these and know what are the advantages and disadvantages, and how to make the best use of it, and what are the suitable candidates for it. So let's start by the optical visual aid. Let's revise some basic information that we mentioned in the geometrical optics. So we said that the magnification, we have two types of magnification. There is linear magnification and there is angular magnification. Linear magnification can be calculated by dividing the ratio of the image size to the object size. So magnification, like here, if we wanted to know how much the magnification of this lens can produce, we can divide the image size, which is 4 centimeters, to the object size, which is 2 centimeters, so it will be 2x. The same value also can be obtained by dividing the image distance from the object distance, or V small divided over the U small, or can be divided by the objective versions, which is U capital, divided by the versions of the image, which is the V capital. So in all these conditions, they will be the same, like 2x. So this is called the linear magnification, and this type of magnification is used in cameras or projectors or other devices used in photography, but they are not used in conjunction with the eye. So what is the type of magnification that is used in conjunction with the eye? This is called the angular magnification, because we have another important factor here in the eye that is called the angle subtended at the nodal point. So to know what is the angular magnification, we need to know what is, or the angular magnification can be identified as the ratio between the image size seen by the optical system of the eye to the image seen without the optical system of the eye. So if we place an optical system in front of the eye, so the magnification will be the size of the image with this optical system to the image without this optical system. Also, it can be equal to the angle subtended at the eye by the image through the optical system to the angle subtended by the object at the eye seen without the optical system. So to just have a quick reminder about it, we said that if we have an object and this object will be falling on the eye through an angle, this is called the angle subtended at the nodal point, and this will stimulate a smaller number of the photoreceptors over the retina. But if we place a lens, a plus lens, in front of the eye, then this lens will produce a virtual smaller image than the original object, but it subtend a larger angle at the eye, subtend a larger angle at the nodal point, so it will stimulate larger number of photoreceptors, so that it will cause increasing magnification. That's how the plus lens used. So the optical system produces a virtual image that is smaller than the original image, but it is much closer to the eye, and the image has larger angle subtended over than the original object. That's why the object appears larger, although the optical system produces a virtual smaller image than the object. The applications of the angular magnification will be that the devices used in conjunction with the eye, like telescopes and hand magnifiers. And for these devices, we said that there is a rule that will govern the magnification, that if the object is placed at the focus of this lens, then the magnification will be equal the power of this lens divided by 4. But if we approximate the object more toward the lens, so the object now is inside the focus of the lens, then the magnification will be equal f, or the power of the lens divided by 4 plus 1. So for example, this we can say, we said before that this is the loop formula. If we have a loop that has 32 diopter power, then how much magnification does it produce? If the object of interest is placed in the focus, then the magnification will be 32 divided by 4, so it will be 8x. But if we approximate the object further toward the inside the focus, then the magnification will be 9x. Let's start with the first example, which is the magnifying high plus lens. So if a patient who has a low vision and we need to improve his vision, we can offer him a high plus lens. This high plus lens is mounted on the spectacles. So this high plus lens will cause magnification, as it will enlarge the image so that it will spread the image over a larger number of the photoreceptors. So if the patient wear just his presbyopic correction or his reading glasses, which is of +2 or +3, there will be a slight magnifying image effect, but it will not be of great effect. But if we incorporate a large plus lens like +5 or +10, then the benefit or the magnification will be much more. So a high plus lens can be used to magnify the image, and it is given over the best distant visual correction. And in order distance, the power should be 100 divided by the power will giving the reading distance. For example, if this lens is +10, then we ask the patient that they will need to read at 10 centimeters. Because as we all know that the +10 diopters will have a focus at 10 centimeters. The magnification is usually about 4 to the power of the lens. So if we use a +10, then as we said, the power or the magnification equals f divided by 4. So the magnification in such condition will be +10 divided by 4. So it will be just 2.5x. So this is very important for the MCQ. It is used for the near work, and the amount of aid needed depends on the accommodation that the patient has and the reading distance. As you can see here, this is the plus lens. This old man is using a plus lens incorporated into his glasses in order to use it for reading. And we said that it also can be used as a low vision aid, or it can be used as a bifocal glasses, as we mentioned in the previous lecture. So you need to know at every modality of low vision, what are the advantages and what are the disadvantages. The advantages here that the hands are free, so they can be used for any tasks. And the field of view is larger compared to a telescope, which is the main problem with a telescope is a smaller field of view. They have greater reading speed because the hands are free, and they are given both monoocular and binocular form, and they are more portable and more cosmetic. However, they have some disadvantages. Then the higher the power, the closer the reading distance, leading to fatigue and unacceptable posture. So imagine that a patient who will wear a glass of +10 diopters need to read at only 10 centimeters. If the book is placed further than 10 centimeters, he will not be able to see it. So this will lead to eventually some fatigue and posture problems. And also, if the patient has eccentric fixation, which also can make up a large amount of patients with low vision, these patients will not be able to use this plus lenses because they will look at the lens periphery, not from the lens center. Another type of the magnifying high lens are the handheld lenses. So the handheld lenses are very useful and very handy in order to magnify the reading, or it can be used to close to the reading material to enlarge the image. We have main two types. There will be the handheld magnifier and the stand magnifier. So they have foot that stand over the surface, so we don't use our hands in order to hold them. The handheld magnifier has a very wide range of power. They can present in different forms, like a spheric that will have flat periphery, so it will prevent the peripheral aberrations, and also can present as aplanatic, so it has a flat and wide distortion, free field, and good clarity. And the biaspheric will eliminate the aberrations from both surface, so they can be both upside down, both can be used in both sides. For these types of handheld magnifiers, usually the patient needs about up to 6 times the magnification that will be sufficient for them. As you can see here, can be used in conjunction with the book in order to have a good view for reading. So what are the advantages and disadvantages? You will find that they are the reverse of the high plus lenses ad will be here in the handheld magnifiers. So here in the handheld magnifiers, the eye to lenses distance can be varied, so we are not committed to the distance of the glasses as in case of the high plus lenses or high plus ad. So the patient doesn't need to stick his book or his newspaper to his eyes. And it can work well with the patient with eccentric viewing, and we can add some light source to this lenses in order to enhance the vision, and it is present at virtually everywhere. But what are the disadvantages? The disadvantages here will be the advantages of the high plus ads. So it occupies both hands. So if you use or if a patient use the handheld magnifier, then he will use his hands, which will then make them unable to carry on another task. Patients who have a problem with their hands, like osteoarthritis or tremors or Parkinsonism, these patients will not be able to use this lens efficiently. Also, maintaining the focus can be sometimes problematic for elderly population, and here we have a limited field of view because of the small aperture of the lens. Another form of the handheld magnifier have emerged to solve the problem of occupying the hand. So it is called the stand magnifier. These stand magnifiers can be placed over the book or the low or the near task, and they can be used over it, so that we don't need to have or the patient doesn't need to hold it with his hands. So if the patient has osteoarthritis or tremors, or if the patient has another task that's present in his hand, he can put this stand magnifier over the book and can maintain his reading. So the advantages, they are of a choice in patient with tremors, and disadvantages that the field of vision is reduced, and the too close reading can be sometimes uncomfortable, and they are blocks the good lighting unless they are self-illuminated, as you can see here. Okay, just hold on for a second, please. Okay, I'm back. Another type of the low vision aid is called the Fresnel lenses. So Fresnel lenses are not like the Fresnel prisms that we discussed earlier, but Fresnel lenses can be used by just reshaping the central lens via a spherical lens by just doing some this should be a GIF or this should be an animated picture. By just reshaping of the spherical lens, we can make like a central spherical lens and the peripheral reflecting prisms. By configuring the spherical lens in this manner, this can be this lens can be used for increasing the magnification. But please make note that the Fresnel lenses cannot be put on glasses. So this type of lenses can't be put on glasses, unlike the Fresnel prisms. So how can it is used like this? This is a Fresnel lens, and you can see clearly that it can cause magnification of the image. So they are used, may be used for the LCD screens like televisions and other devices. The telescopes, also one of the most important devices used for the low vision aids and one of the most expensive as well. They are work on the principle of angular magnification. So they can increase the power of magnification up to 10 times, and they can be used for the near and the intermediate, and they will be the only one used for the distant vision. So all other tasks or all other low vision aids will be used for the near tasks. But the only one that is used for the distant tasks will be the telescopes. What are the types? They will be the handheld monoocular like this, and the clip-on design, and the bioptics that can be mounted on the pair of eyeglasses. So the telescopes can be mounted over the eyeglasses like this, and they can be provided by a source of illumination to enable the patient to see a magnified image. So telescopes will be covered in the instruments lecture. So they can the basic principle or the basic value of the telescopes that it can provide a magnified image of the distant target. So it will be the only object, or will be the only low vision aid that will enlarge the distant image. So for example, this view, you can see that the distant image has been enlarged, but please note that the magnification is inversely proportional to the field of view. So if we increase the magnification, the field of view will be small. If we decrease the magnification, the field of view will be large. This is very important. I don't want to go through the principle of the telescopes, because they will be covered thoroughly in the instruments lecture. But just to have a very quick review of the telescopes. So the telescopes will consist of two lenses. One is called the eyepiece and the objective lens. So there are two main types of the telescopes, what's called the Galilean telescope and the Keplerian telescope. Each one of them can be used for the as a telescope for low vision aids. The main difference in structure, that the Galilean telescope contain eyepiece, which is a negative lens, and the objective lens, which is a plus lens, while the Keplerian telescopes, both the objective lens and the eyepiece are positive lens. They are both can be used for the as a low vision aid, and the magnification of it will be through the formula. Magnification will be equal the focal length of the objective lens divided over the focal length of the eyepiece. So this will be the schematic drawing of the Galilean telescopes and the Keplerian telescope. This will be covered in the instruments lecture. So what are the advantages? The advantages, or the unique advantage of the telescopes, that will be the only device that will enhance the distant vision, but some disadvantages, that it will cause restriction of the field of view, and it's expensive, and not every patient can afford it, and they will show some abnormalities with the perception. Contact lenses can be used as well as a case in case of low vision. For example, if a patient who has irregular astigmatism, like patient with severe keratoconus or advanced keratoconus or scars over the cornea, we can use contact lens of a specific type like hard contact lens or rigid gas permeable contact lens to flatten the irregularity of the cornea and improve the vision. So it can be used as a modality of low vision. Also, there was some enhancement of the contact lens or some innovations in the contact lens called the telescopic contact lens. So by putting a plus contact lens and the minus contact lens, they will act as a Galilean telescope. So they can approximate or they can enlarge the distant targets. So by just capturing the idea of the Galilean telescope, they can be put on a minimal scale in the contact lens. A pinhole contact lens can be used in case of iris defects. For example, if we have coloboma of the iris and aniridia. So you may wonder, okay, but I would think that this will be more cosmetic rather than visual. So does it have any value in the vision? The answer is yes, because in case of defects of the iris and aniridia, these patients will complain of photophobia. So this photophobia due to lack of barrier that will, in case of coloboma of the iris or the aniridia, there will be no barrier that will block the excess light rays that will enter the eye. So this will cause phototoxicity, can cause damage to the macula, and they will impair the quality of vision by this excess light rays. So by putting a colored contact lens that has a central hole, this will block the peripheral light rays and will enable only the central rays to enter the retina, eliminating the peripheral aberrations like chromatic and spherical aberrations, and improving the central vision. Here is the telescopic contact lens. So it combines both plus lens and the minus lens and act as a telescope. Prismatic lens can also be used as one of the optical low vision aids. It can be used for nystagmus. So in case of nystagmus, sometimes the nystagmus, we need to dampen the nystagmus or to decrease the frequency of nystagmus by just putting a prism. Putting a prism base out in each glasses like this can stimulate convergence, because the image will be moved toward the apex, and the eyes will also move towards the apex, and by stimulating convergence, so that will decrease the frequency of nystagmus. So we can put parallel prisms base out to stimulate convergence and dampen nystagmus so that it will improve the vision. Also, in the patients who have blind hemifield, like patients who have homonymous hemianopia. For example, this patient has a temporal hemianopia, so we put a prism. This prism has the base toward the blind side. We mentioned this in the prisms lecture. So if a patient, we put the base toward the blind side, the light rays will be deviated toward the base, but the apex and the image will be deviated toward the apex, which will be the seeing side. Finally, the non-optical visual aids. So these are some low vision aids that doesn't utilize the angular magnification principle in order to improve their vision. For example, the pinhole glasses. This is a glasses with multiple pinholes that has a size of about 1 millimeter holes. So these holes act as a single pinhole. This acts as a single pinhole in front of the pupil, that it will eliminate the effect of the refractive error and will eliminate the effect of the corneal opacities or peripheral corneal scars, but they are not used in the patient who has only abnormal central vision. So for example, if the patient has a central macular scar, or the patient has a central opacity of the cornea, or a central field defect, then this is not used in these patients. Here is the multiple hole or the pinhole glasses. So it acts as a pinhole that will allow only the central rays to enter into the cornea and the iris and the pupil to reach the retina, and it will eliminate the peripheral light rays. The typoscope or the reading guide is a device that can be used in conjunction with the books or the newspaper that has a black interface and only a strip-like clear space. This strip-like clear space can be placed over the line in that the child or the person is reading, and now the child or the person cannot read anything else. So it will just focus the patient attention toward single line. So this will be of particular importance for patients who have like visual field defects. They have marked astigmatism, so they see running letters. It will be of great value. Also, it has some versions with illumination, so that not only it block the other lines, but also the line will be there will be a single line that will be in view, and also it will be illuminated. Writing guide is another type of non-optical low vision aids that can divide the workspace of writing into parallel lines, so that if the person can have a low vision, have a problem with reading into a single line, then the patient can fill in the spaces without any problems. Although there are some electronic versions of this low vision device that is used for signature, so it can magnify where the patient is going to sign in order to that the patient can write on the line and not descend downward or upward, as you can see here. Large printed devices can be also used to magnify the image, so it will fall on large number of photoreceptors over the eye, so it will be easily appreciated by the patients. So this also large print can be useful for this case. Video magnifiers are another expensive device that can be used to magnify the image. So by placing this device over the image you want to magnify, it will produce a large image. It has an advantage of being binocular, so we can see or the patient can see by both his eyes, and since it is electronic, it can improve the enhancement and it can improve the magnification, and has a larger field with great brightness and decrease aberration distortion with long reading distance. But the disadvantage is that not all patients can afford to buy it, and it is not portable except for this device, as you can see, and needs some training and education on how to use it, and it will be of no value if there is wide limitation or large limitation of the visual field. Here you can see that this lady can placing this book under this device, which is now having a picture of this book and enlarging it and presenting it over this screen. Illumination, although it seems simple, but it can also has a great role in improving the low vision in case of low vision aids. So for sometimes patients can need high illumination in order to see clearly, like the patients who have diseases with the macula, like macular degeneration or advanced glaucoma or diabetic retinopathy or retinitis pigmentosa and the chorioretinitis. So here we come to a question. All these patients can need high illumination in order to see clearly, except glaucoma, diabetic retinopathy, retinitis pigmentosa, and albinism. So this can be one of the confusing questions in the exam, and let me tell you something, that this question has appeared in my exam. So you think that these all diseases have low vision, and you are right. But not all these diseases can be treated in the same way, because although the macular and the glaucoma and diabetic retinopathy and retinitis pigmentosa diseases can be managed or can be improved by increasing the illumination, Others will not be or can be worsened with increased illumination, like albinism and aniridia. Because in albinism there will be increased sensitivity of the eye to the light rays, since there will be no melanin pigment. And in case of aniridia, there will be no barrier to block the excess light toward the eye, so this will lead to photophobia and macular toxicity. So in these patients particularly, we need to reduce the illumination. Yes, as I said, in case of aniridia, much light entering into the eye, as the iris should block the peripheral light rays and allowing only the central light rays to enter the eye. So this will lead to glare and will lead to diminution of vision and photophobia. So in such conditions, we need to decrease the illumination, not to increase it. Other non-optical devices is the computer software. So like you may know that every computer or every mobile phone, they will have something called accessibility. So accessibility meaning that it can increase the font size, or making the phone or the laptop talks to its user, so that this can be used as a low vision aid. A breakthrough in case of retinal diseases and dystrophies was what's called the bionic eye. So bionic eye can be used for patients who have severe diminution of vision or who are nearly blind due to retinitis pigmentosa or age-related macular degeneration, which is simply a device that is implanted inside the eye that will transfer the electrical signals of vision to the optic nerve immediately, or to the visual pathway immediately. So these patients can be used. This can called Argus. This is its name, Argus 1 and Argus 2. And this can be tried or has been tried for patients with severe visual loss, and this patient should have a normal optic nerve and visual cortex in order to transmit the electrical impulse, and can't be used for people who were born old. Consists of different devices. So there will be a camera. This camera is mounted on a pair of glasses, so it will act like the patient's eyes, and then this camera will transmit the image to a video processing microchip that is present in the handheld unit. Then there will be a radio transmitter on the glasses, and then there will be a receiver implanted over the ear, and the retinal implant with electrodes on a chip behind the retina. So this will be the only part which is intraocular, received over the retina, that will be implanted in the retina, that will transmit the image from the outside the eye into inside the eye to the optic nerve. So here is the bionic eye. There will be a camera present here in the mount on this eyeglasses, and this will be a radio transmitter. And this radio transmitter will transmit to a device placed over the eye. Then this device is connected to the chip present implanted in the retina that will transmit into the optic nerve. So the camera will capture the image. It will send the image to the microchip. This microchip will convert the image to electrical impulses of light and dark pixels. So here is an important issue. The patient cannot see a clear image or like a normal image by this device, but can see like a black and white dotted image or pixelated image. This image is seen or sent to a radio transmitter that will transmit the impulses or the pulses wirelessly to a receiver. And then these impulses are sent to the retinal implant by a hair-thin wire that is implanted, that by a hair-thin wire implanted. Then this will stimulate the visual cortex. Note that this device requires the training, so it is by the subject to actually see an object. So they don't see, as I told you, they don't see a normal image, but they see a white and dark dots. So they needed training to interpret how or what they are saying. and these are devices are still in the clinical trial stage. So as I remember that the device, the single device, will cost about $1 million. So it is not that cheap. And few trials have been tried all over the world on a smaller number of candidates, because they need a very intellectual patient to in order to protect this device and to know how to use it and to interpret the image produced from it. Okay, thank you very much for your attention. This is the first lecture, and we will take a break about 15 minutes. Then we will be back to continue our second lecture. Do you have any question in the low vision aids? Okay, so we will be back after 10 minutes or after 15 minutes. Thank you very much.